Hello from Liverpool. My name is Peter Satmari. I'm a clinical lecturer in HPB surgery at the university, and on behalf of my co-authors, I'm honoured to present our description of coronavirus-associated pancreatitis. This timeline is taken from the WHO website. It describes emergence of the novel coronavirus to its current form, a global pandemic with over 300,000 new cases every day. Early scientific reports hinted at the possibility of pancreatic injury. SARS-CoV2 RNA was detected in the pancreatic pseudocyst, and we know that SARS-CoV1 is able to infect and damage pancreatic cells and causes acute diabetes. We decided to look back through the cases of pancreatitis seen at our hospital during the peak of the pandemic. We identified 35 individuals with acute pancreatitis based on Atlantic criteria. Of the 35, 25 were excluded as they had no evidence of COVID-19 disease. Of the remaining 10 patients with pancreatitis and COVID, 5 had clear evidence of another defined etiology, leaving 5 that I will now describe further. All patients were middle-aged, overweight males with a median age of 42 and a median BMI of 30. None of the patients had pre-existing cardiovascular or pulmonary disease, and none had diabetes. Only one person was taking any medication in the form of a proton pump inhibitor for reflux. All but one had Charleston comorbidity index of 0. All patients had COVID-19 disease confirmed by nose and throat PCR or CT thorax, and met diagnostic criteria for acute pancreatitis through typical pain and findings on contrast-enhanced CT. 3 out of 5 patients had a mild subdiagnostic elevation of serum amylase, with all samples taken within 24 hours of pain. There were no other etiological factors. Gallstone disease was excluded using transabdominal ultrasound, and none were biochemically jaundiced. All but one patient was practically abstinent from alcohol. None of the patients had been commenced on new medication, none had known metabolic diseases, and there were no iatrogenic causes for their pancreatitis. Contrast-enhanced CT confirmed peripancreatic inflammation without necrosis. Inflammation was largely centered around the pancreatic head. 4 out of 5 patients also had significant duodenitis centered around D2, D3, and there was evidence of marked hepatic steatosis. Markers of systemic inflammation were high. The leukocyte count was pathologically elevated until after day 9 in our cohort. CRP exceeded 400 in all but one after 48 hours. A CRP of 150 or greater is of course predictive of severe disease. All patients met 2 or more of the 4 SIRS criteria 48 hours into their admission. Patients were all managed as per current international guidelines, and no other specific therapy was instigated. None of the patients presented here developed organ failure. 3 out of 5 patients had new onset diabetes, all requiring insulin therapy. 4 out of 5 had features of hypertriglyceridemia, with 2 moderate and 2 severe, which rapidly improved with hydration. Severe hepatic steatosis was seen in all patients on CT. In all 4 patients who had follow-up scans at 1 week, this had almost completely resolved. So in summary, we describe a cohort of patients of homogeneous background presenting with atypical acute pancreatitis. This is associated with the florid inflammation, but no organ failure, as well as acute metabolic dysfunction. We speculate this may represent a direct effect of SARS-CoV2 on the endocrine pancreas in susceptible individuals, but may represent the extreme of a more common feature of COVID-19 disease. I thank you for your attention.